Good afternoon. My name is Kimberly Cooper, and I am the Infection Prevention Manager for Ambulatory Care Services at Harris Health System. I am a registered nurse and CPHQ and CIC certified, and have been working in infection prevention for 11 years. I wanted to give some insight on to our abstract safe practices through automated surveillance in an ambulatory surgical center. Surgical site infections are amongst the most common reported healthcare associated infections. One component of a successful outpatient infection prevention program is hospital associated infection surveillance. However, reviewing charts manually and relying on providers to self-report in labor intensive and limited, where we also discovered that in average, the response rate was 30% with no identified post-surgical infections. We know that this surveillance style reduces time spent and other quality-driven projects. During the height of COVID and monkeypox, we needed to optimize time spent reviewing charts and cases. Our goal was to develop an automated surveillance platform for ambulatory surgical procedures, improve patient outcomes with early identification of SSIs, reduce SSI infection rates by implementation of best practices supported by SSI root cause analysis. And we also wanted to create surgical bundles and best practices based off of those findings. The project was launched in 4 phases, beginning in the first quarter of 2021 to implementation and go live in January of 2023. We created a surgical site dashboard and provided user access. We identified key indicators and tested with new triggers within the electronic health record, such as return to the emergency department or positive drainage for surgical site infections. We also modified current triggers to decrease activity with the data, as well as we ensured that the outpatient criteria denominators data was accurate. As we worked through each phase, we continued to retest and refine the data for accuracy. In phase 4, we met to create a process workflow while moving to production of NHSN and non-NHSN denominators for surveillance. Once launched, we immediately began to identify SSIs from the outpatient ambulatory surgical center, which in the past had gone undetected. This project simplified and standardized the surveillance process, which will improve overall patient outcomes because best practices can be implemented when surgical site infections have been identified accurately. The method was an overall success. By abstraction of accurate and reliable patient data from the electronic health record onto a centralized dashboard via automation, where this information was compared to NHSN standardized criteria in the outpatient setting. In conclusion, our team identified that the use of the automated surgical site surveillance identified more infections than previously reported, as well as improved communication between surgeons, administration, quality, and the infection prevention team, which will mitigate the risk of surgical site infections, creating safe practices and improving our overall patient outcomes. Thank you for listening to my presentation on safe practices through automated surveillance in the ambulatory surgical center. If you have any questions, we can be contacted at kimberly.cooper@harrishealth.org. Thank you.